everybody. Welcome to Mater GP education session, and thank you for joining us. My name is Fiona Hinchliffe and I'm the Director of Mater at Home.
My name's Jeff White and I'm the Allied Health Service Unit Lead.
So we're going to talk to you today all about Mater at Home and what we do, and also how you can access it or help your patients to access it. So thanks for joining us today, and I'll start by telling you a little bit about Mater at Home and what we do, or just refreshing your memory if some of you have already had interactions with us in the past. And Jeff will really go into some more detail about how you can most easily access our services. So Mater at Home, just by way of introduction, Mater at Home has been delivering healthcare services into people's homes for 25 years now. And what we know is that there's been an increased shift towards person-centred care, where people are taking more responsibility for their own health, and they're also wanting to access services closer to their home. So the demand for services like Mater at Home is growing and expanding in its reach, and in also the types of services that people can receive at home. Mater, as a leading health organisation, does not see itself simply as a collection of hospitals providing excellent care. We know we do that. But Mater is also a collaborative community partner with an undertaking to empower people to live better lives through improved health and wellbeing. So for Mater at Home, our prevailing remit is to optimise people's functional capacity and health and wellbeing, so as to keep people safe and well in their own homes and out of hospital and out of care facilities. So by way of quick summary, just looking over the year that's just about to close out, we have received over 10,000 referrals. We've visited people over 31,000 times in settings outside of hospitals. So this is in the home or in workplaces, in schools, universities, under verandas, in the garden, wherever anyone needs us to see them. We see people via telehealth, we see them in community settings, and indeed in some GP practices. So as this slide shows here, of those visits, just over a third of them we provide to people who are existing Mater patients. So they would be people who are transitioning out of hospital and into home. So we provide them some acute or subacute services. But over 2/3 of the people we see are from the wider community. So referrals from other hospitals or referrals mainly from GPs. Also, people will refer themselves. They'll access the My Aged Care portal and request Mater at Home via that, or other community professionals and family members. So we are in the community, engaging with as many members of the community as we can who would otherwise not necessarily engage with Mater. So while we do provide pre and post hospital care, we also provide acute care via our Hospital in the Home program, and this diagram depicts how our service integrates with the hospital and with community care providers, with general practitioners, to provide health and wellbeing along the continuum of health, from wellness through to pre-surgical preparation, inpatient care via our Hospital in the Home team, through to post-acute care and rehabilitation and back to wellness. So Mater at Home is positioned to partner with GPs, with hospitals and with the patients themselves along that health journey. So in our current model, we have preventative health care. We provide maintenance of care or restorative care, and treatment of chronic disease and rehabilitation, and acute and post-acute care. So we really span that spectrum of health from acute inpatient or rehabilitation through to wellness and restorative care. On our team, we've got over 85 staff now, and it's a full suite of professionals. Our medical team, we have infectious disease specialists and some general medicine physicians. Our nursing team are highly skilled clinical nurses. Our allied health team consists of pretty much the full suite of allied health. You can see there physio, OT, speech, nutrition and dietetics, psychology, social work, podiatry, and we've also got allied health assistants who carry out a lot of our ongoing programs with our patients. And we've also got an intake team and management administrative team and a fleet of 37 vehicles at this stage. Just to go into those programs a little bit more, in terms of the preventative health, what we offer are group or individual programs, and the group programs are run in community facilities. These are evidence-based programs and outcomes driven. So we do have our therapy goals that are achieved at the end of these group sessions. Some of our group classes are falls prevention and balance classes, and they're conducted in multiple locations around Brisbane several times a week. Well, they haven't been conducted during COVID. We're looking at re-establishing them fairly shortly. We also run nutritional classes for healthy ageing and mindfulness as well. Again, we specifically target the older population, but we do also run nutrition and pregnancy workshops. Marta at Home is also a registered provider through the NDIS, and we've found that there's been a rapidly growing demand on our service for this. And we've had to really adapt ourselves to delivering this care, and it's become really one of the hallmarks of our services. So this care, as you would know, is to support individuals achieve their personal, social, occupational and health goals. Jeff will talk a little bit later about how we can assist you to assist any patients you might have access the NDIS. So then if we look at our acute care, this is our hospital in the home service. And whilst this is a service that really our MARTA patients access, I've included this today to tell you about, just so that you have an idea of the breadth of our service and the capability of the our clinical team. So our acute care service is a mature and multidisciplinary HIT service. We offer IV antibiotic infusions, immunotherapy, and more recently blood transfusions and blood products. We've started doing iron infusions at home. So our service is able to provide access to a full inpatient team, and because of that, it represents an authentic hospital substitution for suitable conditions. So while the HIT services are primarily nursing, we can very often involve physiotherapy, say for our cystic fibrosis patients, occupational therapy, social work, psychology and dietetics might also be required. So we delivered several thousand public and private hospital bed days last year through this service. Our team also disconnected over 600 cycles of chemotherapy and delivered 200 subcutaneous treatments. And so each of these events saved what could be an exhausting trip for people undergoing care, and our feedback is that it's had a great impact on the lives of people being treated for cancer. Our post-acute care is primarily for complex wound management or post-surgical drain management, nephrostomy tube care, etc., vac dressings. We also do care for home assessments and modifications for people exiting hospital, for swallowing and dietary management, for reconditioning and rehabilitation. And these services allow for an earlier discharge and a safe transition to home for many of our MARTA patients and patients from other hospitals as well. In partnership with our emergency department, we've assisted several hundred of our most vulnerable community members to avoid hospital and reduce hospital presentations by conducting a welfare check. So this is where any member of our team, it doesn't matter if it's a nurse or a physio or a social worker, will go and set eyes on someone in their home that the ED physician is worried about on the same day or the next day. And what we'll be looking at there is checking the home for its health and safety, so making sure there are no food false risks, also looking for signs of polypharmacy, hoarding and squalor, access to foods, security, etc., and what the general state of well-being of that household and what sort of care and care supports are available. And I'll talk a little bit more about how this is now available for GPs to access as well. Also there you'll see postnatal care, which is our champ at home, and there we work in conjunction with MARTA Mothers Hospital, where we support pre and postnatal women who have issues with alcohol and other drugs to be connected in with their community. So we follow them into their home for 6 months after the birth of their baby and make sure that they're connected well in with their primary health providers and any other supports that are in the community. As previously mentioned, our multidisciplinary team supports post-surgical, medical and neurological patients to regain their condition and ability within their most salient environments. So we've found great success in giving people some restorative care or rehabilitation programs in the environment that they're living so that they can make the best use of that environment whilst doing their exercises, etc. And finally, our MARTA Aged Placement Service. This is a fully independent brokerage service, and we set this up. It's available for families who are trying to negotiate the complexities and intricacies of finding a care placement for their elderly loved ones. So that's a very brief overview of the scope of our services and gives you an idea of the team involved and the breadth of our skill and expertise, I guess. And this is just a bit of a snapshot and not all inclusive, but a snapshot of who it is, who we're working with. So adolescents and adults with disability, orthopaedic patients, neurological patients, the frail, the elderly, those with chronic disease, but also people who are well and who are wanting to take care of their health and retain their independence and well-being. So MARTA at Home is by nature an integrated service, both internally with the MARTA. As you can see, we catch a lot of people as they're coming out of the MARTA and we try to prevent them going in, but also externally with our communities and primarily with our GP referrers. And as an integrated service, we can't be static and we refuse to be system-driven. So as an integrated care, we need to be responsive and adaptive and be able to present to meet the needs of the healthcare needs and the social needs when and where they're needed. And COVID actually gave us a good chance to illustrate this. So this slide just talks about the MARTA at Home COVID response. So MARTA at Home, the HITS team of MARTA at Home actually cared for over 90% of the MARTA COVID positive patients, or the patients who are assigned to the MARTA by the public health unit. So our response required coordination and flexible thinking. Really, it was without critical incident. We had one transfer to hospital, but it was primarily because of anxiety of that particular patient, and they were able to be transitioned back onto our HIT program. All of the patients on the program were of the low risk, apart from one who had some social concerns and we looked after. And they all recovered, thankfully, 100%. During that time, none of our staff became ill. So we were very tight with our procedures around this, having very strict admission criteria, and we were in close contact with our clinical governance and public health. And also we with the GPs whose patients we had on our program. The other thing that we stood up during the COVID response was very similar welfare check that we run with ED with our GPs. So GPs were invited to contact us if they were worried about their vulnerable patients and how they were coping at home. So while we were all trying to keep people away from presenting to hospital, presenting to ED, and indeed presenting to GP surgeries unless absolutely necessary, this service we were able to visit people in their homes and do that general welfare check. So we could send a nurse out who could have a look at how that person was coping and if there were any signs of concern that might need escalation or the consultation with another team member. So a nursing and allied health screening assessment was done. If necessary, there was a coordination of social supports. We also kept an eye on how people were coping with isolation and whether or not they actually were receiving support from family members or neighbours. And if not, we're able to link them in with appropriate community supports. We were also able to check the home for safety and any false bricks, and then implement our normal services as required. So it was essentially a hospital avoidance program. We'd very much like this program to keep going in post the COVID surge. And so we'll be working with you on establishing that and embedding that as a part of a service to GPs. Also in line with that, the Queensland Health, through their Health Innovation Unit, has given Mater at Home some funding to implement a hospital avoidance program. And initially this funding was into home residential aged care facilities. However, what we have realised in examining this was that in fact there's no gap there. That's not where the service is required. Care Pact, as you would be aware from Metro South, and Radar from Metro North, are supplying a very comprehensive hospital avoidance or rapid response, ED response into aged care facilities. So we felt that the funding would be better directed to a very similar model, but into people's homes, because we now know that people are staying in their homes for longer. And so there is still a very vulnerable group who maybe 3 years ago might have been in a nursing care facility, are in their homes. So we're working currently and establishing a team so that we can have a response, an emergency response into the home, where a number can be called. We can send out a team member, most likely one of our clinical nurses, who can then interact with the GP. Where necessary, we can do some telehealth consultation into a geriatrician or emergency specialist and determine what is the best path of action, best wraparound service required for that person in their home. So again, we'll be calling on you to be engaged with that, and we'll let you know we're very close to getting that up and running. So I'm now going to unless there are any questions that have come up on any of those things, I will hand you over to Jeff, who's going to talk about who's eligible for what in our programs and how they can be accessed.
Thanks, Fiona. So as you can see on the slide, it's a bit of a brief overview of our different funding programs. The ones with asterisks, you'll see that these are ones that you could access to refer to us. But just to talk a little bit about them. So hospital in the home, as Fiona mentioned, it's a direct substitute for inpatient care. So the client is admitted to hospital, so they become an inpatient, and then they're transferred to the HIF ward. So there's a few different methods for that admission. You'll see the point about transferred to HIF via virtual admission, ED admission, so GP to the HIF SMO. So currently that's by special arrangement, but we're sort of working on making, streamlining that so it's easy to access. Post-acute care is, so this is for our non-private patients, so patients without private health insurance. So post-acute care, that's where they've been admitted to hospital and then they're actually discharged. So it's a little bit different to HIF because HIF, they remain an inpatient, where post-acute care, they're actually discharged. So those referrals would generally come by the ward staff. With post-acute, we generally try to see them within 2 weeks. Well, actually, we try to see them within the first week if possible, because often they're still a bit vulnerable or they need that extra input. But yeah, we always try to see them at the latest within 2 weeks, and sometimes that's dictated by the client as well. Then we move on to outpatients. So outpatients it's essentially home-based outpatient treatments. So it's something where a client would normally be referred to like a physio outpatient department. We can actually see people under the same funding type, but at home. So an example from a physio point of view would be like Achilles tendinopathy. Certain conditions are better treated up at an outpatient department, but we can certainly provide good treatment in the home, and particularly when they can't access it. The next one, which would be quite relevant as well, is the Commonwealth Home Support Program, which we call CHISP. So that's for clients. So going back to outpatients, they essentially have to be an adult. However, with Commonwealth Home Support Program, there is a little bit more limitation. So they have to be 65 years or older, or 50 years and older for Aboriginal and Torres Strait Islander. So with the CHISP, there has been a bit of a notable change with our the CHISP guidelines. So previously, I guess we could accept direct referrals from GP practices and hospitals. However, with the changes, it essentially requires every client to be referred to My Aged Care by a service, and then the referral comes from My Aged Care to us. So I've put the link to the website. So from your practice, whether it doesn't have to be a GP, it could be the practice manager or the nurse. They can make a referral through My Aged Care. And I think it's the next slide. I'll just talk a little bit more about the process, because you can specify MATA at home. So for CHISP or Commonwealth Home Support Programs, the client has to be registered with My Aged Care. So if the practice could complete the My Aged Care referral on the portal, and it's on I think it's the second last page, which is the recommendations page. You can actually, with additional information, you can request MATA at home. We do understand that sometimes referrals can be urgent and there's a bit of a concern. So for those ones, we still need to actually have a My Aged Care referral. As I said, it's part of the CHISP guidelines. However, what we can do is, if you complete the My Aged Care referral and then so you get a confirmation code, and then you can contact the MATA at Home office directly, and we can do a referral over the phone. And then, and we just get that confirmation code off you, so then they can be seen urgently. Then MATA at Home is also set up for private patients as well. So we do run the HIT service under private. There's a few, it depends on the health fund, and it requires approval from that health fund before they can come onto the program. We also do rehab in the home. So that can be on certain program types as well. Again, it requires approval from the health funds, and there's a few programs set up where they're covered for a certain amount of visits for a certain amount of weeks. It's quite common after surgeries, particularly total hip and knee arthroplasties. However, we're also set up to provide rehab, not so much on the programs, but just under the health fund rebate, which moves on to the next one. So MATA at Home set up to see clients under their health funds, and we can go out and see them and then invoice them, and then they can claim the rebate through, if they've got private health extras. We're also, we see home care package clients. So That's for clients that are, again, it's similar to the CHISP guidelines for the age limits, and I'm sure you're aware of the home care packages level 1s to 4. So we've got multiple agreements with different home care package providers, and we do have plenty of clients that they might be with a new one, and we just go through a process of setting up a new agreement with the new home care package provider. The thing with home care packages, we do require approval from the case manager, mainly to make sure that, that they're aware of it, and there's also funds in the package available. We have NDIS, so I'll talk a little bit about that now. So for pre-NDIS clients, so these are clients that haven't connected in with the NDIS yet. We do encourage, if we get contacted by a client or if you have any questions, we're happy to contact the client, and we will ask them to apply directly to the NDIS. So they have to start that access application process. So they'll either be themselves or a carer or an advocate. So they'll be seeing, they'll contact the NDIS, and sometimes it can go forward, and then other times the NDIS can request supporting documentation for the application. So generally that could be a report from GPs or a confirmation of diagnosis. NDIS can actually request functional reports, which essentially are pre-planned reports. Unfortunately, at this stage, there's no government funding for pre-planned reports. So pretty much the main option at the moment is for a private report. So we can do that for NDIS or pre-NDIS clients, and it is a private service only. Generally speaking, it takes about 5 hours total. So that'll be 2 hours of a visit face-to-face and then 3 hours to complete the report. We have found that some clients have gone to their NDIS planning meeting and unfortunately haven't got the funding that they've needed. And then through the appeals process, they've engaged our services or even, gone back and actually got more hours and, the funding allocation they need, particularly, if there's some assistive technology that's needed. For clients that are actually approved, so either they're newly approved or returning, the process that's followed is, we'll receive a referral. So most commonly we get it via email, or we can take referrals over the phone. The Mater at Home, we've got a team which is dedicated to NDIS. So they'll formulate a quote and service agreement, and then they send it to the client or the support coordinator. They'll then decide whether they want to proceed, and if so, they'll return the signed agreement, and that's when treatment can commence. And that treatment will continue until funding allocation is exhausted. At the end of the treatment, they will provide a plan summary. So that's the summary of the work that was completed for each discipline. And we'll also provide a report for any future needs, so they can take that to their next planning meeting or the planning review, and for the next year's allocation. We can actually, so Mater at Home clinicians can actually support them in that planning meeting with the patients, and it can actually come out of their current funding, so they can utilise that funding to assist with the next year's plan. The other option we do have is, and this can happen quite commonly, that they may be allocated, as an example, say 15 hours to physiotherapy and 10 hours to OT. And then after the initial assessment or throughout the treatment, it's kind of realised that they actually probably need more hours for OT and less hours for physio. We can actually interchange that funding and allocate, so take some of the funding off physio and allocate it to OT, as long as the client agrees and it's in line with their goals. And for referring to Mater at Home, there's a few options. So our referral form and our information is available at Mater Online. I've put the link in for the referral form, but we can always send that out as well. But we accept emails via email and fax, referrals via email and fax. And we can also take referrals over the phone. As I mentioned earlier with the CHISP or Commonwealth Home Support Program, is the My Aged Care portal, and just you can request Mater at Home. As I said, to expedite the process, if you want to give us a call saying that you've put in that referral, and we can take that referral again. I know it's a bit of duplication, but it's part of the CHIS guidelines. So once we've actually seen the client, so what you should expect, if we do actually have your email address, so we do encourage you to put your practice's email address on the referral. Once the referral is accepted, if we have your email address, you will receive it is an automated email, but it will specify the approximate wait time. And I guess if you had any concerns with that wait time, you could always give us a call to discuss and we can look into that. But you should also expect a discharge summary for the clients that you've referred to us. So if there's any questions around that, feel free to ask.
So that's really all the information we have for you. So I have questions. We're very happy to take them via email or at any later stage. You've got the phone number there if you would like to phone us, speak with myself or with Jeff directly. That's quite all right. So unless there's anything else, I'd just like to thank you all for joining us this afternoon.